Thank you all for coming today to listen to Paula Foster, who is a clinical associate here in the School of Nursing and just recently completed her master's thesis. She's going to share with us today her project about cultural safety and integrating cultural safety as a routine aspect of primary care. So I'm going to hand it over to Paula to further introduce the topic.
So hi, yes, I'm Paula Foster from the School of Nursing. I'm from Vancouver. I'm pleased to be here today to talk about cultural safety in healthcare and in nursing education. So I want this to be an open dialogue as well as for hopefully you to take some awareness away from today's session as well about your own thoughts and beliefs and knowledge about cultural safety in healthcare and Indigenous health and social services. I'd like to introduce Laurel as well. Jebamani, would you like to introduce yourself? That'd be great.
My name is Laurel Jebamani. I'm Aboriginal Health Lead at Vancouver Coastal Health. Prior to my health authority life, I worked with Dr. Paula Foster. So back in UBC Hospital.
Yeah, Laurel was one of the key people that I collaborated with at the Aboriginal Health team at Vancouver Coastal, bringing my thoughts about cultural safety and what I wanted to do as a student and working with her team. So she's part of my thesis committee. And Dr. Colleen Varco was key mentor and support supervisor for my thesis. Colleen Varco as well. Do you want to say hello as well, Colleen?
Hello.
Thanks so much.
I don't know any of this. She's painting a pretty picture. I was actually not a mentor and support. It was more like a
Thank goodness for that. Yeah. So thanks everyone for being here today, and I would just like to take the time just to say an acknowledgement that we are here on the traditional, ancestral, and unceded territory of the Musqueam people. And what I'd like to us kind of talk about today, and my intentions for today, are to promoting and opening dialogue, like I said, about your own beliefs and values about cultural safety, the roles and benefits of cultural safety in nursing education. Why do we need to do it? Increasing your own knowledge and self-awareness about cultural safety approach to client care and healthcare, and discussing what we can do as nurses and educators in our role as advocates to address racism in healthcare context. For me, it's about us all as individuals taking action in speaking out about racism in healthcare and cultural safety. So that's my kind of commitment as an educator and citizen, is to really take action and bring it forward and make some change. So that's kind of where I'm at now, having done what I've done in my career, long career as a nurse, and worked in different countries and with different cultures. So yeah, I hope that's kind of my takeaway message and where I'm coming from. And I'll explain a little bit more as we go on about why I came to be where I am. So, and a bit of background, I got married young, and when I finished my nursing program as a Canadian educated Pakeha nurse, I went to New Zealand with my Kiwi husband. And that's where I really learned about working with different cultures. It's opened my mind and kind of inspired me throughout my career, having worked and engaged with Maori people in New Zealand. So some really neat and inspiring things that I learned there and saw and witnessed as a nurse, and which forever changed my practice, is as soon as a patient enters the healthcare system in New Zealand, they always have a family member with them. As soon as they enter any healthcare kind of interaction, there's family support until they leave the facility. So much so that I had a patient in the intensive care unit who died. The family were there throughout, of course. And then what happened once they died, instead of going down to the mortuary in a smaller New Zealand, like rural setting, the family just pull up in the car and take the patient home to the marae. So, that just blew me away, as you can imagine, from my previous background here in Canada as a nurse, where I'd worked at Vancouver General, and we didn't even talk about death hardly, let alone having often family members touch a body and engage and really discuss about their culture in depth. So that forever changed that. I think forever changed my perspective on health and death and dying. Also, in the Maori culture, they will always like bring children in as well as part of the healthcare experience. And so touching the person who's sick and engaging contact, physical contact is really important. Of course, engaging with the land is really important as it is with Indigenous people here in Canada. Other interesting things that I really learned a lot about was having different linen for different parts of the body as well. So if we're using pillowcases, you know how we'll support people with pillows behind their backs, under their limbs. Well, you'd always have different colors for the head, which, you know, from infection control purposes makes total sense, really. So they had different linen for different parts of the body that we would use. And another thing that I really miss when I came back to Canada was, because my background is intensive care, so I went back into critical care when I came back here. And when we'd have a patient die, you know, of course, we're getting the next patient back in as soon as possible. Well, I was used to blessing the room. So in New Zealand, you know, I was taught by some of the Maori colleagues I worked with, we would bless the room after somebody died, and then that would allow the spirit to leave the room. And then the next patient would come in, and all of us would feel a lot more at peace with that. And that, because you must have all experienced that as a nurse, you know, when the turnover of patients is so great. And, you know, sometimes you have one patient's deceased and the next patient rolls, and it's like the karma in the room isn't always the same. You want to kind of make that best experience for that new patient who comes in. So that, again, really stayed with me throughout my whole career and still does. And I didn't feel quite right when I come back here, and it's like something's missing, because I really wanted to do that here as a nurse as well. But when I kind of brought it up, people were like, wow, you mean you did that? Like, they just couldn't really relate to it. I found when I discussed these kind of things with colleagues when I came back to BC in 2000. So I came back, worked in intensive care, started questioning things to myself, and then, you know, teaching was the same, working with students in urban setting with Indigenous folks, primarily at Providence Healthcare. Again, opened my eyes to a lot of questions that I had. So I wondered, why do disparities in health outcomes continue to exist for Indigenous people? Where was nursing and cultural safety approach to patient care? Why were family not welcomed or accepted as part of the plan of care to assist in Indigenous patients' health and well-being? I think, yeah, any time anyone wants to sort of jump in with questions or their own addition, please let me know. So why is all this important? Why is it important? Any ideas? Well, I hope you're all aware, like the tripartite agreement that's between the First Nations Health Authority, federal government, BC government, you know, that's a legal binding agreement now that we have that, you know, First Nations Health Authority, more awareness to bring self-determination for First Nations people, making us aware, integrating their models of wellness and health and well-being into the healthcare system, which is pivotally important, which wasn't previously there. And BC still is the only province to have this agreement in place. So health outcomes, as we know, there's still disparity between Indigenous and non-Indigenous people. There's some small, slow progress happening and some improvement, but still are a lot of health inequity gaps between non-Indigenous and Indigenous people. Particularly life expectancy still 81% for non-Indigenous versus 75% for Indigenous people. In terms of the Truth and Reconciliation related recommendations from 2016, again, there's a lot of really important things in there for us to take away in health and education. So recommendation 18, the shift is recommended for us to shift the focus from patient blaming to system enabling. That's a quote from one of the recommendations. And also, again, discourse in health and education, that there are gaps, that the gaps that exist for Indigenous people are the results of social and policy changes, past and previous, that are still ongoing. So it really named where the blame should be, which is really important for us to remember. And just, it relates to a lot of the findings that I had in my study. And also provincial regulatory organizations that we belong to, such as CRNBC, and all the really big ones here in BC, College of Physicians and Surgeons, the dentistry, pharmacy, etc. They've all pledged our member commitment to practicing cultural safe care as health care practitioners, which is flow on from the tripartite agreement as well. Anything you want to add about that tripartite agreement, Laurel, or how that's impacted health?
I think it's actually coming to its anniversary because it was just over 10 years ago, but it was meant to be a 10-year plan. So I'm hoping to see from the provincial health officer some sort of close report to show what progress has been made. But yeah, we continue to use it.
You might want to repeat some of the things from the audience that you can't hear.
Oh, okay. So the context and what is important about all this is, as I've talked about, so the context in which Indigenous health inequities occur, and the way social, historical, political, and economic factors have shaped and continue to shape Indigenous people's health. And the context that we're talking about here, so, like I was saying, so why Indigenous people still have drastically different health and social outcomes. Is there something wrong with the system? How we're understanding these issues is kind of critical in how we move forward. So my thesis, I'm just going to run through some of the sort of mentioning some of the areas of the thesis, and then I'm hoping that we're going to spend more time on the findings and some discussion. Okay, so I won't spend a lot of time on the key points. So I kind of looked at origin of cultural safety, which of course started in New Zealand with Ramsden, and who again was kind of similar. She was looking, Maori nursing theorist, a nurse who was looking at why do we have all these health inequities with Maori people. It's kind of where it started, and started questioning social, political, historical structures in a colonized country such as New Zealand. So we could take a lot of parallel from there to here in Canada. Power structures, that's kind of where the origin started. Cultural safety, we also know, can really only be defined by the client. So they're the ones who determine what is culturally safe nursing care. Cultural competence, which we hear a lot more about perhaps in nursing and here in BC, is having the knowledge and skills as a healthcare provider to deliver culturally safe care. And that CRNBC, CNA discuss that as an important aspect of nursing and attribute. So I looked at the origins of cultural safety, cultural competence in the literature. Cultural safety is a framework for viewing healthcare and nursing care as well. Well, I guess since for me working in New Zealand and adopting a cultural safety approach to my own nursing practice and healthcare is kind of what I've always taken forward from that. And what is that? Well, yeah, it's client-centered care, seeing the whole patient, inquiring who are they, who's this person? Do they have any preferences, cultural preferences I need to know about? Asking those questions, inquiring of any patient I have, so I'm not just making a judgment on someone appearance. This person, it probably is a person of culture. So we should be asking that of every client, right? So having that cultural approach and commitment and intent, looking at the client and their context. Indigenous health inequities, I won't go on about those, but I looked at where we're at with that, what we know about that. Post-colonial theoretical perspectives, again, that's kind of what I've been talking about here, and it's a really good theory, relevant theory to again analyze the social, political, historical context of a colonized country such as Canada, why Indigenous people are where they're at in relation to Canadian history and context. Power differences that have come of that and the systems that are still in place, which are barriers for health and equity with Indigenous health. Champions in healthcare, well, being a positivist, and we were wanting to work with, and I was working with the Aboriginal team who were looking at the policy of health, cultural safe implementation in a hospital in one of the health authorities. So I was hoping my work would inform what they were doing in terms of the context and the healthcare providers in this hospital. And so we were hoping that this would kind of stem more people to be thinking about cultural safety and champions, and they would kind of be spreading the work, a good work about what the Aboriginal patient navigators do and the champions of cultural safety. So I had to look at kind of champions in healthcare and what was that about, because we're trying to instill positive change. So yeah, a champion in healthcare is someone who's passionate, who's taking up the work, whatever the kind of new innovation or progress is that needs to be moving forward, and really talking to their colleagues and making change, someone who is seen as a lead in that. Which I do kind of mention in my, I've just listed a few definitions here. I did have more in the thesis, but I'm just going to move through these quickly. So cultural safety, an outcome based on engagement and recognizing and striving to address power imbalances inherent in the healthcare system. A champion, like I said there. My own definition of the champion of cultural safety, so an individual who role models respectful, client-centered, culturally safe care. So I kind of wanted to make it simple because it was challenging in a way to find people who wanted to speak to me, who felt that they could identify as champions. And then when we kind of had the discussion, and then I, brought it down to the grassroots of this kind of simple definition, people are like, yeah, I do that. I'm afraid to kind of call myself a champion, but this is the kind of care I do provide. And so I was hoping that that definition would resonate with people for the study, and also kind of going forward when they're discussing with their colleagues as well. Even the Aboriginal patient navigators were kind of very humble about their work and seeing themselves as champions. So my purpose in question was exploring and understanding the perspectives, behaviors, experiences of the champions of cultural safety within this hospital. They were primarily the Aboriginal healthcare team members. There was, and one elder as well, and some healthcare providers as well. So the questions I had, which I've kind of been alluding to, I think you'll probably be able to work them out. Have the champions kind of describing their experience and perspectives within the organization, how they enact cultural safety day to day, the contextual factors within the healthcare organization that affect uptake of cultural safety, implications for nursing practice, education, policy, and research. So as I do want to get on to the findings, and there's a few, I do want to just mention the methods as well. Method section, so the design, so it was an ethnographic exploratory qualitative study. The participants were recruited by convenience sampling, and I started with one of the Aboriginal patient navigators and discussed cultural safety with them and how that kind of happens in terms of referrals and in their line of work and kind of understand how they enact their role. And this, then it kind of came, basically my participants came slowly over a 3 to 4 month period. Interviews were done with semi-structured, in-depth interviews because I wanted to get that rich description from the participants. And the analysis was inductive thematic analysis. So now the findings. So the client and healthcare provider relationship's the cornerstone of cultural safety. So for you nurses out there and in here, that shouldn't be kind of a shock to hear, I don't think, that the nurse-client relationship is the cornerstone of cultural safety. Basically why that was so important, and that was kind of most of our discussion, was that everyone wanted the time to be able to really assess their patient, connect with their patient, understand who this person was in the healthcare experience, where they came from, and what it meant to them. So we all work in time-pressured healthcare situations, but this is the kind of the theme that resonated with everybody, is making that connection, hearing their stories, how important that is. And then another flow on from that is, you know, client safety flowing from respectful communication. What do you think about that in relation to sort of what you've heard so far? How important that is, or what are your thoughts? So really listening to the client, as it says there, and understanding who they are, building that trust, which is so important, because if we don't, taking the time and if we're rushing, for some Indigenous patients who've had negative healthcare experiences, that trust may take a while to happen and open up. And so if we're not using, you know, taking time to sit with them, possibly, if that's what's indicated and what's needed at the time, that open listening, who are you, what's happening with you, where are you from, you know, what are your needs, what can I do for you at this time, all really important, so that, you know, we're being open to this person, who we are, and really giving them their time and attention is super important. Building that trust so that they are feeling safe. And they did, some of the participants' experiences are that, particularly that trust can take time to build up, and our healthcare system, being the biomedical model and kind of get it right, diagnosis and disease-oriented system, does not always, of course, you know, value the time, the safety, the trust, the healthcare provider-client relationship. So the APN's Aboriginal Patient Navigators practice cultural safety through advocacy, spirituality, and communication. So what I found there was, so advocacy, super important. Right, Laurel? That's the main focus of their work. Do you want to speak a bit about how important that is and what they're doing in terms of advocacy?
Well, I mean, the name of the position is Aboriginal Patient Navigator. Okay. Okay, sorry.
Okay. Sorry, we're just getting Laurel to come to talk about advocacy.
Where am I talking into here?
This year, yeah.
Well, their position is called Aboriginal Patient Navigator. They're helping patients navigate a system that they don't understand, that they're apprehensive about. They've probably or possibly had negative experiences in healthcare settings in the past. And these navigators are helping them go from one part of the system to another and ensuring that the staff understand that perspective and the importance of the respectful communication, taking the time. They're really building capacity within the organization, within whatever facility they're working in, of the staff to be more culturally safe in their own care.
Great, yeah. Yeah, and the spirituality was super important as well to clients. And my feeling was often, which we'll get to, some clients weren't aware that they could even ask or that was available, but it's certainly becoming more available with the APNs bringing in bundles with them of their traditional medicines so that they can meet the spiritual needs of the patient as well. Communication was an interesting one for me, but not a surprise. But some of the experiences they talked about was having to kind of be a buffer and navigate with other healthcare providers. So what I mean by that is that often when it came to visiting time and having family members at the bedside, again, our system doesn't really value that or accept that. There'd be some tensions often between some staff members and family members who wanted to be present throughout the patient's experience. So the APNs are great at coming in and listening to the healthcare providers, listening to the client and family needs, and then, coming to an arrangement that worked out for the client and family, but also that healthcare team as well. And just kind of explaining, we can have people, at the bedside, but perhaps not 5 or 6 people, but kind of coming to something that was satisfying for both parties there. And so this really links well with that finding that what we just talked about was that no surprise that the Aboriginal patient navigators are the primary cultural safety strategy. So just to give you a minute to look at that. Anything you want to add about that, Laura, in terms of the organization and the work that they're doing, kind of numbers of APNs?
There are 4 of them, and they work across all PCH sites. We could easily use 8 of them or more. Because 6 hospitals in PCH.
Yeah.
I mean, they can't be everywhere at once. So it's a real challenge. They are the ones working with the frontline staff. So myself and the other leads, we work with sort of manager level folks and director level. My executive director works with directors and senior executive team. But the patient navigators are the ones who are working directly with frontline staff. So they're really in a position to make the most impact.
But that's super small numbers because we're talking about wanting to refer clients to the Aboriginal patient navigators who need the services with very small numbers, but also be getting out there and teaching staff and role modeling culturally safe care and implementing a lot of the changes of cultural safety throughout the organization as well. So that we're asking a lot with the small numbers. So healthcare providers that I talked to, and the healthcare providers came from psychiatry, psych unit, social work as well, with an acute care setting. And their perspectives and experiences, again, very patient-focused, very family-focused, wanting to connect with the patient as the individual and where they were at, who they were in the healthcare system, and what their individual needs are. I just want to add that the next finding because just talking about their perspectives, but then the constraints, or kind of echoing from what I said before, was the setting, the system, the hospital structure, the time and workloads. So those kind of echoed for both the Aboriginal patient navigators and definitely the healthcare providers heavily, the time, the setting to create that relationship. It's not valued when their workload is such that as the social worker has to, move patients along with discharging, etc. So again, there's sort of just some tensions between the values of the individual and the organization itself. Is this resonating with anyone who's here today? Yeah? Yeah, for sure. Yeah.
So you mentioned there's 4 patient navigators of PCH. Is that all of PCH, like Vancouver, Richmond Coastal, or just Vancouver?
No, that's all 3 communities there, yeah.
Oh, wow.
Yeah, it's not very many.
Yeah.
BC Women and Children's have their own patient navigators as well as St. Paul's Hospital. So those aren't covered by our patient navigators, but yep, everywhere else.
What's the typical caseload of HPN navigators?
Around 50, I think. Although we're trying to shift our focus to be more staff capacity building rather than client support, because ideally we would like to get to a place where patient navigators aren't needed because the frontline staff are all providing culturally safe, respectful care. So that's sort of our end goal.
And just another piece to the healthcare providers' experiences and perspectives, they all said that how they benefited so greatly from doing the PHSA Indigenous Cultural Safety online course, which I have a link to at the end for you, for those who haven't done it. It was all that, wow, I didn't really know what that was about, our history. I had never been taught it. You know, I feel so horrible that I didn't know anything about residential schools, Canadian Indigenous history. So it was really impacted their learning. Just wanted.
One day? Is that the one day? I've done.
No, it's not one day. It's no.
Oh, that's an online.
That's the online training. Yeah.
One, I think it was Jennifer and.
Okay. Right.
Oh,
yeah.
So you did our in-person training.
Yeah.
Yes, and
Mm-hmm.
it was amazing.
Yeah.
Like
Mm-hmm.
so great. So yeah.
So just looking at some of the experiences and perspectives about the organization strategies from the champions. So they brought forward that they felt that it was the strategies by the organization were insufficient in the structure that they're working in. From some of the reasons that we've talked about in terms of the time and pressure context, the biomedical model context, which we've talked about, and the facilities themselves. If we think about bringing in elders, APNs, bringing in traditional medicines, a lot of the facilities do not accommodate that in terms of, they're old buildings, ventilation, if we're wanting to do smudging, it's just not always safe. Well, that's perceived as unsafe. If that starts, if it's been done in hospitals, and there's been a lot of resistance in some areas about that. Any update on that?
Vancouver Coastal Health actually has a policy, as you probably learned in our training, to make space for ceremonial healing, including smudging. And we're currently revising that policy, and I'm trying to advocate for including language around requiring all renovations and new builds to be ventilated, to have space that's ventilated for smudging. I just was in Richmond last week discussing a new facility that's being developed, and I went there with Elder Roberta, and we were saying, you know, is there space that's going to have ventilation for smudging? And they were pushing back. And I was like, there's a policy.
Yeah.
But then, it's because it's more money and slows things down. It's always that fight. Like BCH is very into this lean thing. I think it stands for something, but it's something that was developed out of like assembly line car manufacturing, and it's all about like, let's cut as much as we can and make things all streamlined with as little as possible, but it's completely in contrast. Like it just doesn't work for this kind of relational, slowed down work that's really necessary for truly culturally safe care. So it's a bit of a tension.
So being aware of the Indigenous ways of knowing and well-being and health is super important as a healthcare provider to be culturally safe. And some of the, like I said, a lot of the healthcare providers didn't know about that until they had taken the PHSA course. So they were very grateful for that. But then it seemed to sometimes stop there, in that the resources about the sacred space room, which were available, and the fact that there are APN resources, and there is a website with what Vancouver Coastal Health does for Indigenous people. That wasn't kind of used by the staff. They didn't have time to use it. They weren't really aware of it. So that was interesting. Sufficient resources and supports. We've talked about that already in terms of low numbers. And the healthcare providers definitely all really supported more resources. In fact, having an Indigenous APN on the healthcare team, we don't really think of consulting and having someone come aboard with a complex care patient. Why not? Because that can really make a huge difference. And I heard many stories of how often an APN may be brought in very late with a healthcare provider team, and they always made a huge difference to the patient's recovery. More visibility as well. We're talking about resources and support, and that's kind of in progress with, at the time last year, public visibility for the staff and the patients in terms of Aboriginal health supports. So the structural barriers persist in the social colonial context, and this, as we know, is in society and in political, judicial system, healthcare organizations, as I've talked about. Structural violence, and that flows on. Thoughts on structural violence? Colleen, do you want to add something there? I'm sure you would.
I think it'd be interesting for you to tell a little bit about the kinds of encounters that some of the patient navigators had that they described to you.
Yeah.
I see you've got it right there. Yes.
I do. Yeah, that one. There's many. There are many. Particularly, it seemed to be often with staff who would, be discriminatory, stereotyping, and then family would, sometimes family would contact Aboriginal patient navigators, or the other team members would, and this came on, then the Aboriginal, again, patient navigator would get involved kind of a bit late, but nevertheless, thankfully became involved to improve the healthcare experience for the patient. These, there's several instances of very unsafe care. One particular story that really resonated with me was the APN was saying how there was a patient who had admitted for seizures and was being discharged home, and the physician basically said on discharge, well, all this patient needs is a couple drinks and it'll be okay to go, because that's all they need to help them with their seizures to treat. And this was said, within the last year. So we try to kind of think of racism and discrimination as kind of the elephant in the room, like we don't want to talk about it. And we think that it doesn't happen, but it happens day to day. And this was a patient who didn't even drink alcohol. Not that it wouldn't matter anyway, but that was an aha moment for me, for sure. Anything you want to add about racism? Of course, the APNs, having all experienced racism, discrimination, stereotyping themselves, as Aboriginal people in our society, we're very, sensitive to that, and certainly enriched a lot of the study and my findings about that.
I guess one thing I would like to point out that I learned a few years ago was that experiences of racism are detrimental to your health in and of themselves, never mind trying to navigate a racist system. So even just walking down the street of someone uses a racial slur against you, it negatively impacts your health.
So just a summary of the findings, which was the complexities and intersections of the healthcare provider and the client relationship, the organizational strategies to support cultural safety and the current systemic structure, and processes which constrain the participants' abilities to provide care. I did my discussion, part of my thesis included was kind of a flow on from what we've just seen in the findings, which flows from the client healthcare provider relationship again, and the context and the characteristics of the current conflicts within the system and hospital and cultural safety. So I won't go into those because I want to kind of jump onto just the kind of implications and discussion, because that's kind of what I hope to achieve and kind of stimulate some discussion from this. But I might just ask Laurel first to maybe just give like an update on where the Aboriginal health team's at with implementing cultural safety and cultural humility into all the healthcare organizations.
Sure.
That'd be great.
Well, when we started working with Paula, we're focusing our work on a particular hospital, which then we encountered a lot of challenges, part of which were centered around another transformational change project that they were involved with, and so they were super excited about taking on another transformational change project. What we're trying to do is change the culture of hospitals and health facilities, and that's a big change. So we actually ended up switching to a different facility. And I think a lot of the challenges that Paula outlines in her presentation and her project were behind the necessitation of that change. But it is going ahead. This picture that you see here, this is Chief Ian Campbell. He's a hereditary chief from Squamish Nation, and our department has contracted him to provide cultural safety, nation-specific cultural safety events, sessions to staff. So this is him in the hospital that we are rolling out the pilot in, providing some information on Squamish culture. We are still going to work with the original facility. They're on our 2019 horizon when that other transformational change project is finished. Hopefully it will be by 2019.
Yeah.
But so that's one aspect of what we're doing. We have also created a little cultural practices guidebook. So a lot of what Paula was talking about, around the pillow and never using a pillow for someone's head and then also for their legs. Just these small cultural details that a lot of people don't necessarily know, and it can lead to a lot of misunderstanding and unintentionally. So we've created a little sort of a flip guidebook for hospitals to just like a reference manual, basically, to refer to if they're caring for an Aboriginal person. And it's got stuff like that, and then beginning and end of life care, what to do with hair and nail cutting processes, that kind of thing. So that's being distributed at this hospital and others. We're developing very short, well, as you mentioned, we have a half-day in-person cultural safety training session that we are actually rolling out to the senior executive team next month, which I'm really excited about, because one of the things you talk about is the need for cultural safety at every single level. And we've also been rolling it out with various teams across the health authority. And we're also starting to develop shorter, like 30-minute presentations, as well as talking about how the APNs can get into team huddles and short team meetings and get cultural safety information out to teams in that way, because as we've talked about, there's not a ton of time to provide this education once people are in the workforce.
So we might try to go into the discussion, because that might cover some of the policy and implications for education, etc. So what can educators do to support the Aboriginal Health Team in working towards a climate of cultural humility and system-wide change from what you've heard? Ideas? what can we do? What do we need to do? Well, there's a lot of work to do. It's very small steps as Laurel can attest to this. So we need to, I encourage you to read, reflect, and ask questions. So what is not going on where you're working in your healthcare setting, no matter where it is? How is culture being assessed? Are people inquiring about that as part of their holistic assessment of their patient? That was something that I didn't talk about with limited time in terms of the findings, that the healthcare providers definitely said there's no real formal assessment tool for a cultural safety assessment about a patient, or even on our flow sheets when we're assessing a patient when they first come into hospital, even a tick box of asking that question, do you have any cultural preferences? I think in the CST, I've heard that that's changing, thank goodness. So there's consistency amongst healthcare providers from when they enter into the emergency department. So then, I get the patient next, and we can see that has already been assessed, or what did you find in the emergency department about that patient? So that's great. Asking questions of those who have more understanding about cultural safety, finding allies and creating a support system for yourself that can help you advocate for culturally safe care and approaches. So acknowledging Indigenous knowledge, traditional medicine and ways. Hey, yes, Ali.
I have a question for you. It's not really an answer to your question, more of a question back, which is, I'm wondering if you got a sense of from your participants, both the reach of awareness about the services, for example, AHT. Did it seem that the perception was that a lot of the healthcare providers and staff were aware of the resources, or did you get the sense that there was a gap there?
A gap, yeah. Yes. Because it wasn't really talked about amongst the interdisciplinary team in terms of, again, because of that holistic assessment, that little piece of culture wasn't really brought in by the team. And then, people had taken the course, but then they kind of used it as an individual knowledge awareness, but didn't really always enact it or know what to do in terms of looking for services within that system. Yeah, that was common. Committing to lifelong learning. We all know that as educators and nurses. SANIAS.ca, the PHSA Indigenous Cultural Safety Training we're talking about, I highly recommend that. Definitely CRNBC recommends that as well. And now that there's a commitment for cultural safety practice as healthcare providers from our regulatory body, it's pretty much sounding mandatory. Also, what I really enjoy is the National Indigenous Cultural Safety Learning Series webinars. There's a link to that as well. They're super great because they're national, and it's a collective of people with like-minded interest in cultural safety, cultural humility, and you hear speakers from all over Canada, and that's really enlightening. So I highly recommend that as well. Any others you wanted to recommend, Laura?
No, I think those are good ones. If I can.
Yeah.
I have a question from our online audience.
Okay.
That is from Alison Burlock. Did you have any findings that speak to how you teach students about identifying and addressing social determinants of health as routine practice?
Could you state the first bit again? How did I find?
Did you have any findings that speak to how we teach students about identifying and addressing social determinants of health as routine practice?
Not within this study. I didn't really look at education specifically, and really like nursing education of students. In my own practice, and we're talking about holistic assessment and patient-centered care, then I do bring that forward as a piece. But no, I didn't really look at that in this study. It wasn't kind of beyond the study. But Colleen, would you like to add?
Well, you did see the extent to which the patient navigators were having to advocate even around basic resources and social determinants of health. So right?
Sure.
Not just, so it's a different question, how do we teach that? But your data certainly underscore the importance, right?
I could maybe, from the health authority perspective, because I envy this setting where you have a lot more time to build knowledge rather than like, okay, you got to get everything in there in 3 hours. It's because we're trying to change the culture of the facilities. Like I remember early talking to Colleen about we're trying to change the who's uncomfortable around the water cooler when racist jokes or statements get made. We want the people who are having those thoughts and making those statements, those to be the uncomfortable people, not the people who are currently uncomfortable because people are laughing at racist jokes. So it's really teaching people about Canada's history, Canada's colonial history, but getting them to really almost take ownership of it as a person, not just as a nurse, not just as a professional person, but as a human being. And that's where you get to those champions, by really getting to their hearts and helping them understand. Like, imagine someone coming and taking your 4-year-old away from you against your will, and then the next time you see them, they're 16 and addicted to alcohol. Think about that and think about how that would feel, like getting to people's hearts.
Yeah. Imagine sitting in the emergency department when we'd be there if I was there with a child and the child was bleeding. I'd be expecting somebody to be coming pretty soon and assessing that patient, my child, and getting care. But imagine sitting there and sitting there and sitting there because you're an Indigenous woman who's brought their child in, and the care that you're going to get and attention could be a lot different. And I definitely heard that from some of the Aboriginal patient navigators and the elder I spoke to. So there's still a lot. We know there's lots and lots of cases in the media that we hear daily that still happens within the healthcare system. So we still have a long way to go. I think in answer to education question before from Allison, which we better get to in terms of implications, a cultural safety framework as educators for students. So adopting a cultural safety framework and focus, and then the intent in terms of teaching and assessing clients and their social determinants of health is within the literature as a suggestion of how to teach cultural safety and education, and particularly working in partnership with elders and Indigenous health departments as well is key. And bringing in real life case scenarios, like we've talked about, and what might be going on and how would we respond as a healthcare provider if we're in a situation where we're seeing a patient being ignored in the emergency department. Which might be a good lead into Colleen's current work in the EQUIP study in the emergency departments in terms of policy and education and practice. It kind of all comes together quite well in terms of that. Did you want to speak briefly about that?
Well, we only got
very brief.
Yeah,
a couple of brief.
Staff are here.
Yeah, but I think it's a really good link.
Right, but for the few of you that don't know about this, we have, first of all, last of all, I've asked Joel to speak about our online modules, but we're just doing a study in emergency where we're trying to see if we can take that idea of champions, not just of cultural safety, but of equity, rights, and care, and use it in emergency to see if we can shift the culture in emergency through an intervention. And part of that, and like all the educators in the room to know that they're coming online and available, are some modules. Do you want to just quickly describe them?
Sure, yeah, really quickly. So part of what we did coming out of the first primary care study was we started to build a toolkit tools for providers in health and social services around the different dimensions and practices related to primary care. And then we just recently launched the pilot phase of these online modules. They're 8 modules that kind of unpack the different dimensions of equity and embed the toolkits with a little bit of context about how to use them and some of the knowledge behind them. We've got videos and activities and worksheets and things like that.
Yes.
So it includes trauma and loss, informed care, cultural safety, harm reduction. It's got all kinds of little tools, like how to respond to discriminatory comments, to use those as tools in classrooms and so on.
Yeah. Go ahead. Yeah.
Not about quick stepping.
Sure.
So I appreciate how you brought out the theme of time as being an essential component to lead into cultural safety through kind of that respectful listening. And I was wondering, given that time equals money in healthcare systems and that it's a closed system of money, right? They're not necessarily getting more money. It's like, how do we use the money we have? How would you use your findings or pitch some of what you've learned through your research to make that argument?
For more Aboriginal health resources?
For more time.
For more time for healthcare providers.
To have those interactions that can then lead to cultural spaces.
Well, I think it goes back to having like the values of the organization and the mission statement values and the key, what are we trying to achieve and for who, and what our priorities are, and really committing and having that intent, and then seeing it enacted through flow sheets and different systems of way of models of care. So I think that starting from that and seeing that trickle down, that has to happen due to the agreement that's in place and declaration of commitment that all the chief executive officers have signed from the health authorities. So they have to be accountable to that, and there's quality assurance and assessment and follow up and reports about how well is the organization doing, what evidence do we see that the implementation's working. But there's a lot that we don't know, because in terms of evaluation from healthcare providers, from patients, there's tons of research that can be done. So unfortunately, I think we're out of time, and I really appreciate all those who attended, and for Laurel and Colleen as well. And I hope that going forward, this is kind of giving you some self-awareness as an individual and a nurse, and open your eyes to your kind of work situation and what difference you can make. So thanks so much. Thank you.